2021. And our patient here today has back pain. She has several herniated discs. The worst ones are L34, L45, and that's right where her pain is localized to. You want me to turn you? So we're going to be treating the L34 and L45 discs. She has herniated disc at 3, 4, 4, 5. We're going to get started. We're treating her back pain. Hi, Dr. Duke here. How are you? You ready to get started? All right. So I need your help. If you feel any pain, just say ouch. You want to try? Let me hear it. I want to hear an ouch. Good. Now, when you say ouch, I'm going to want to know, is the pain in your back or is it shooting down your leg? So say ouch, my back, or ouch, my leg. All right? Now, if you don't have any pain, just get comfortable. And I'm going to be talking to my team. I'll probably talk to you a little bit as well. I don't want you moving around trying to pick your head up, okay? So is your neck comfortable? Perfect. We're going to get started, okay? So she has left-sided pain, and she's got a herniation that's more on the left side at L34 and more on the right side at L45. So we're going to do a left L34, and I am standing on her left side. I'm just talking out loud. I'm going to give you some numbing medicine, okay? So you're going to feel a little stick and burn. That's totally normal. I apologize in advance. That's the numbing medicine. It's going to make it feel a little better for you, okay? You feel that? All right. So that's for the left side, 3, 4. And next, you're going to feel a little bit on the right side as well. And this will be the right side for 4, 5. I apologize. Just hang in there. You're doing fantastic, by the way. We're going to put you to sleep soon, I promise. I just need your help in the beginning. All right, 8 cc's injected. You okay? All right, you're fine. Remember, you're going to let me know if it gets uncomfortable, okay? Just say ouch. You don't have to say ouch for everything, but if it's really bothering you, say ouch, all right? You got it? Deal? This is left. You agree, Luis?
I agree, sir.
So we want to keep the anxiety down a little bit, Doc, but still feel pain. Just one ouch. It's okay. We're giving you more medicine. You're fine.
Can I have one more? I'm sorry.
Did Santiago use ketamine?
No, sir. No.
Oh, okay. I thought he did. Okay, whatever you prefer. Shot. You need to have a wider window. We're on the left side right now, so I need the X-ray to the left side. I think you're a little too far north too. Okay. Oh, you did. That's fine then. All right, let's go lateral so I can see a lateral view. So the first step in the surgery is always navigation. And what I'm navigating is a needle, or 2 or 3. Depends on how many discs and sides I'm fixing. So we got to navigate. That's, way too restricted of a view. So I need you to show me more in the back. I need to show me more down below. So show me the sacrum and show me more of the back. Shot. That's good. All right. More sacrum. That looks like 2, 3, right? Shot.
Yes.
So 5, 1, 4, 5, 3, 4. So we're too high. Okay. So we're going to numb things up a little bit lower. Putting pressure. You're doing great. Just relax. This is the worst part of the surgery for you. We're just giving you more numbing medicine, okay? Just be patient with us. Let me see the other side. there is xylocaine, right?
Yes, sir.
You're fine. Everything's okay. Let me feel. Uh-huh. A little more pressure. Let's get the blood pressure down, please, Doc. Are you working on anxiety or blood pressure or both? All right, perfect. All right, so while we're waiting, let's go ahead and get the fluoro set up better. So you got to get used to helping me get the fluoro lined up, okay? So your collimation is fine. What we need is at 3-4, which is, we're on the left side, so we're going left 3-4. You need to get those end plates lined up. She's got some scoliosis. You have to fix that. Can you see that? So while I'm doing other things, you should be adjusting the fluoro position and getting it right. Otherwise, you're just wasting time. This should all have already been done. Do you understand? That's much better. But I got to see the sacrum. You see how the end plates are parallel now? So I got to see the sacrum though. Otherwise, I don't know what level we're at. And I would drop the table just 1/4 inch. All right. So now I can see 5-1, 4-5, 3-4. And we are left 3-4, correct? And 3-4 looks pretty good. You got the end plates lined up. I think we can get the pedicles lined up just a little bit better. So I would say it's a 1 degree wag one way or the other. Pick a side and we'll just see what it does. Shot. Other way. It's the wrong way. So 2 degrees the other way. And that's perfect. I guess that's 5-1, 4-5, 3-4. She okay? All right. Are you comfortable? All right. That's good. I'm asking her. But you know what? I'm happy you're comfortable. Shot. I want you to be comfortable as well, doctor. All right. So I just need to see the sacrum. That's the problem. Unless we can see the sacrum, we don't know what level we're at for sure. Is she comfortable? I'm just going to go a little bit lower. You're doing great. Shot. Don't move. You're somehow, so the parallax, right? You moved your base south. You need to adjust your wag. You got to do all this without me telling you. Otherwise, you're causing a delay. Shot. These are basic X-Ray Tech 101 kind of things. Yep. Jordan's got it. Uh-huh. So 3-4, we could just do a little bit better with the pedicles. Just a little bit. Yeah, that's good. I can live with that. Because the 4-5, the 4 pedicles are good. So 4, 5, S1. Okay. Just lay still. Shot. Okay. So I'm making my way over to her facet. I need some num-num. Just lay still. It's okay. You don't need to move your body. I just said say ouch. No, yeah, the Versed won't take the pain away. You know that. So Versed is an anxiolytic. It reduces anxiety. Our patient is extremely anxious. And when people are anxious, their response to pain is hyper exaggerated. Hers is hyper exaggerated. So, shot. So my goal here with the anesthesiologist is going to be to reduce her level of anxiety so that when she does feel a little discomfort, she doesn't try to jump off the bed. Shot. Oh, I can't work with your finger there. Yeah, just lay still. Don't move. Shot. You're doing great. Just don't move around. So we got to be careful. We don't want to give her too much pain medication because I need her to feel pain if I get too close to the nerve shot. But I don't want her flopping around like a mullet. You know what a mullet is, right? Shot? Yeah. Shot. Anybody seen a mullet before? I'm not talking about the haircut. Shot? All right, so I'm just a little bit lower than I want to be. You're fine, just lay still. You're doing great, I promise. Shot? So she's moving around a little bit, which is not terrible. Come on, when I look up at me, when you see my hand move and I look up, it means you take a picture. Okay, don't make me sit there and have to wait. You comfortable? Shot. Are you there? Can you hear me? Can you hear me? AP. So at this point, I'm low in the foramen, which is good. And I'm going to be getting an AP view just to make sure I like where the tip of the needle is. I feel the herniation. I can actually feel it. Look at the scoliosis. So we're not fixing her scoliosis lateral. We're actually just fixing the disc annular tears. Can't do that. So it just takes a little, thinking to know that as you're going around, you have to go down to time it. Okay, so let's go lateral. Oh boy. All right. Shot. All right, thank God one is down. Now we're going to go to the other side. So what should you be doing now? Lining up 4-5, right? So let's do that. When we're done with 3-4, we're ready to line up 4-5. So go ahead and get the end plates lined up. You had it before. That's definitely moving in the right direction. I think you need a little bit more than that. See the pedicles of 4 down there? Try to line them up. How's she doing? Yep, you're not quite lined up. I don't know if you went past the point or if you have to go the other way, but just kind of figure it out quickly. All right. I think we may need to, there's definitely scoliosis going on there. I think we have to do some orbiting. So maybe bring one side up or down and let's see if it gets better. Shot. That definitely got better. That's actually pretty good. That's pretty darn good. I mean, there's bad scoliosis at 4-5. So, and we're going to 4-5 next, correct? Right approach.
Yes, sir.
So here we go. Right approach at 4-5. Let me know if you're feeling discomfort, okay? And usually the skin is pretty painful, which we numb up. And then the soft tissues, like the fatty tissues underneath, are not so bad. But then shot. But then you get to the fascia. There's a dorsal fascia, and that's not fun for patients. It's uncomfortable. It's very pain sensitive. And then you get to the facet joint. I think I need to start a little lower. You feel that? Let's give her some more num-num. It's almost like this stuff doesn't work on her. It's weird. Have you noticed that? Sometimes local doesn't work on certain people. Do you feel that? All right, so we'll find out. Well, let's give it a second here. We're gonna We're going to find out. So it seems to be working better now. Shot. So I'm going from the other side to the 4-5. That's because at 4-5 her herniation is more to the right, this is the right side. This is the left side. So at 3-4 the herniation's to the left. At 4-5 the herniation's to the right. So it just makes sense to do this way, to make two separate incision shot, and to try to fix both sides. Just lay still. Everything's okay. You're doing fine. Shot. 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 Any pain there? Shot. You doing okay? Shot. I'm not asking the anesthesiologist. Shot. Are you okay? How is she? Can I rely on her? Shot. AP? I mean, it looks good here on the lateral, but we need to check the AP view. Take your time. Let's get a good AP. Are you comfortable? Is that a yes? Good. Project your voice so I can hear it. All right, that looks amazing. We are going to have you to sleep in just a few minutes, and you're going to wake up. We'll be done, okay? But I need your help for just a couple of more minutes. Have you ever watched the Duke laser disc repair surgery before? Did you watch it? Did you ever watch the links of the videos we sent you? What did you think about it? Are you ready for your test? Huh? Do you remember what happens now? What happens? Okay. Is she reliable? Is she awake enough? How bad is that on a scale of 1 to 10? All right. Is that where you typically get your pain? Okay, good. We found one of your bad discs. Isn't that wonderful news? And so when you wake up, that'll be gone for the rest of your life. That's one of those discs. That was the L45. It was causing your pain. Is that better? Are you better? Are you better? Is it eased up? Okay, good. You still feel that pain anymore? All right, she said no. You comfortable? Good. How bad is that on a scale of 1 to 10? Is that where you typically feel pain? Congratulations, we found the 2 of your painful discs, and when you wake up, that pain will be gone. You get to go to sleep now. I'm not going to torture you anymore. I want you to count from 1 to 100 out loud. Start counting. Yeah. Concordant at 3, 4, and 4, 5. We're all in agreement that that is the 3, 4, 4, 5, right? That 5, 1 just looks weird. But I still feel very comfortable. That's 5, 1 down there. So we're at 3, 4, 4, 5. Everybody in agreement? Good. 5, 1 looks like a normal disc. Okay, you can put her to sleep, yeah. Count out loud from 1 to 100, please. Don't, what? Yeah, that's the medicine going in your arm. Don't worry about that. Count out loud for me. Shot. So at this point we're removing the spinal needle because we don't need it anymore. We've already done with it what we needed, navigation and discogram. Now we're going to make our 7mm incision. Are you awake? All right, thank you. Perfect. Nice job, doctor. So you live in Orlando? And where?
Okay.
I didn't understand what you Ocala.
Yeah, next to Gainesville.
I was just in Ocala this weekend. Have you heard of the Ocala Grand Prix?
Really? We have a Grand Prix?
Yeah, you do. It's a famous go-kart track. The Florida Winter Tour International race was there this weekend. It's off of Williston Road. Where do you live? Off Silver Springs?
No, I live in southeast Ocala.
Southeast. So that would be the first exit, right? South.
Exit 350.
Yeah. Where do you like to eat in Ocala?
There's nothing to eat in Ocala except Red Lobsters and other
Red Lobster. My God! Please don't tell me you eat at Red Lobster. Do you eat it? Have you eaten at Amaret Palace?
No.
What nationality are you? You don't like Indian? What are you? Persian?
No, Egyptian.
Where from Egypt?
Cairo.
My family's from Alexandria. Yeah,
No.
100%. I'm not making it. Alexandria. My father left in '66 when Nasser was in power, and he was persecuting all the Christians. The whole family left. They came to New York and then Los Angeles. That's why I'm from California, LA. Here. I call it Smell-A.
I was in California for 10 years.
I'm sorry to hear that. Where? Irvine?
No, I was in Palm Springs.
Palm Springs, very nice.
I went to Palm Springs for 10 years.
Where in Palm Springs?
Desert Regional.
Desert Regional? You must have seen my PA. Well, he left about 10 years ago. Augusto Cienciabella?
I left.
He worked with the orthopedic group down there. Big ortho group.
Yeah, I left California in 2000 and left.
Oh, no, he may have left right around that time. He came and worked here. He trained at Stanford, PA. He was an orthopedic in Argentina. We miss him, but like I said, he got lulled away by evil forces. You know, like you see in the movies, good people being seduced by evil people. That was him. That's his story. Take that. How's she doing? Good?
Yeah.
So you're from Egypt. You must be very smart.
Not really.
Yes, you are. Did you go to medical school there?
I tell you, I'm smart because I came here because it's terrible over there.
Did you go to medical school there?
Yeah, I went to
So you took the national exam. You must have done top 1%.
I took the exams here again. I did the residency in Miami, fellowship, Jackson Memorial Hospital.
Where did you learn your English?
Basically, we studied in
Egypt. There's still, yeah. Oh, it's very nice to meet you. My father has passed away. He died in 86, 87?
86, that's
Yeah.
the year I came here.
Yeah, he died in California in 86. I was 16. All right, take that. I'm Armenian. You know, many Armenians went to Egypt to escape persecution from the Muslim Turks. The Turks hated Armenians. They hate anybody that's not Turkish. Or Azeri. No, I hate the Turks too. My wife told me you should be open-minded and forgive and forget, right? It's Christian values. So I tried. But then they're killing Armenians again just this year. How can I keep forgiving people that keep killing my people? We've done nothing. Peaceful people.
So you were talking about paying back for people who did that. So the Turks should pay back for the Armenians.
They what?
The Turks should pay back
Of course, restitution. They should pay the Armenians. The problem is, in the United States, our Congress won't recognize the Armenian genocide as having occurred. They deny it. And they deny it because we have very, very big military and political interests in Turkey. So the American government has never recognized that genocide because it's not in their political interest. You understand? Huh?
What is it?
Yeah. It's because it's bagging. Because you don't have suction here. You don't have suction here.
Probably school.
Wait, just wait. Here. Give me some suction. Give me suction. No, you don't. Give me suction on the line. My line. Go. Come on. Hello, McFly.
There is no
There.
suction
Yeah,
plug over
that's
here?
fine. No, there's no plug there.
Should be there.
Huh? I know, because I'm putting it here.
No,
This isn't cut.
the other side. This is two sides. So one should be.
There's nothing here. I don't know what you're talking about. Oh, that.
Yeah.
It's
so
too
it-
high. Just forget about it. We're fine. Just keep this guy down here, and we're fine. Okay, let's get back to work. You're welcome.
You don't need with for this
What?
one? You don't need for your scope?
No, I never use it for the scope. If I put the suction on for the scope,
Yeah.
then it will suck it'll create air bubbles, and I can't see anything. So I never use it. We use it at
Why
the
is
end.
that?
We use it at the end.
Okay.
We use it at the end.
But I thought that helps to.
Why is the suction? Oh, here it is. It's on. All right, give me a blue towel. Give me something here. One of these. Are these okay?
Yeah.
All right, here we go. Sorry about the distraction, but there we go. That's a little better view. What? There's the tear, by the way, for those of you wondering. When I move the tube, you can see the sides of the tear shaking, doing a little dance. So how long have you been living in Ocala?
2002.
Why did you choose Ocala? There's nothing there. Well, I mean, you know, there's horses, a lot of horses. No? There was a guy named Dr. Seipert. George Seipert? Seipert. My God, that guy was a monster in spine surgery years ago. He used to do like 15 laminectomies a day. He made gazillions of dollars. I'm not jealous or anything. I'm a little jealous that he had such a comfortable life doing such an easy surgery. I could do it. Huh? He was in Ocala. I've heard stories about him. He was one of those people you hear stories about. You know, I'm sure that they have stories about me now. I just don't make gazillions of dollars. They've cut back on the reimbursement so much. But that was back when he would make, like now we make $1,500 for a laminectomy. Back then, he would make $30,000, $40,000, $50,000. It's nice not to have to worry about your business, whether it's going to be around, if you're making enough money. Medicine has changed.
We're talking about the 70s and the 80s.
70s and 80s, it was better. Yeah. Shit, I mean, I look at the payments even for like C-sections, you know? When my dad was doing C-sections, much better, much less now. The insurance companies are keeping all the money. And I gotta tell you, people are so dumb, they don't even see it. They have no idea where the money's going. They think the hospitals and doctors are taking it all. Why in God's great earth are we dripping? Luis, you should have a V with the bottom of the V being this thing right here.
Yeah, so what
Not
happened
not
is,
top and bottom.
Yeah, I see what happened is.
Yeah, I know.
The top sheet is on top of the suction, so it's full the bag over there.
It's all right. You live and learn, right?
Yes, sir.
And make it better next time. All right, so we are inside the disc at L34, and this was a 10 out of 10 pain. So why is it hurting her so bad? The answer is it's inflamed. Imagine you have somebody who has pimples on their face, really red, tender, big, juicy pimples. And they also have tiny little bumps that are not pimples. They're just skin tags. You know what I'm saying? Anyway, if you put your finger on the skin tag, it doesn't hurt. But if you put your finger on that juicy pimple and push in, it hurts like hell. What's the difference? They're both on the skin. They're both lesions. They're both masses. The difference is the pimple is inflamed and the skin tag is not. It's the inflammation that causes pain, folks. So if you have a tear in your disc and it's inflamed, it will hurt. And it'll cause pain for the person every day until the inflammation's gone. Most of the time your body can heal the tear and get rid of the inflammation on your own. However, in some patients, they're unable to heal the tear and get rid of the inflammation. So there's constant inflammation inside the annular tear, and that is what causes chronic back pain or chronic neck pain or chronic thoracic pain. I had a neurosurgeon who works for the insurance companies. He's in California, and I'll refer to him by his name. His name was Dr. I am a whore for the insurance companies, and I'll lie through my teeth to make money. That was his name. It's a long name, but it's a just name because it truly describes who he is. And he was arguing with me saying that, oh, I can see you published papers for the neck for cervical disc herniations, but not for lumbar. First of all, I did publish as well for lumbar, but he didn't know about the publication because he didn't read any of the papers we sent him. And he was there to deny the surgery and represent the insurance company. That's what they pay these doctors for, is to say no. The surgery is not necessary. All right, and patients are not getting their surgeries done because these pieces of SHIT doctors are lying on behalf of the insurance company because they're getting money to lie. So this guy, I explained to him, it's the same. A herniated disc in the neck is the same as a herniated disc in the back and the thoracic. And he just wanted to argue and argue and argue. He refused to read the papers that I sent him that were published after peer review. And the funniest thing of all, which is not so funny, is that this was a TRICARE patient who wanted the laser surgery so badly she had waited years to get it covered. So we submitted to TRICARE. Now we have already proven to TRICARE that the Duke laser disc repair is medically necessary and not experimental. And as a matter of fact, that proving that we did required us to go to trial against the United States government, represented by Humana military, who did the denial for the surgeries. And after 3 days in front of a federal judge, giving testimony, reviewing the patient's charts, each one individually, spending 3 full days, having expert witnesses, the judge decided, as well as the Defense Secretary of Health for the Defense, they all decided that the Duke laser disc repair is medically necessary and it is the standard of care. It's not experimental. Humana was trying to get out of paying for the surgeries by saying it was experimental, which is what these insurance companies do all the time. It's their go-to strategy to not pay for a patient's surgery. So we fought it and we won. This is with TRICARE. And the government paid for the surgeries and sent us a summary of the court finding, which is that the Duke laser disc repair is medically necessary. So this doctor I was talking to, the neurosurgeon, this piece of garbage in California that's hired by Humana military to say that the surgery is not necessary and it's experimental. And I even told him, this has already been decided in court for TRICARE, and this is a TRICARE case. And he said, I don't know. I was just told to call you. Totally unprepared, totally not caring. And these are the peer reviews that I have to do for my patients with doctors that are not really interested, and they're certainly not my peers. Because I actually would consider a real doctor to be my peer. Someone who took the Hippocratic Oath to help patients, first and foremost, help patients, and he's clearly not helping the patients. He wants to help the insurance company. So I'm just talking about this because you're not asking questions, and I want you all to know the truth. That's what you're up against, crooks. Like this neurosurgeon from California who is lying and disregarding all the evidence that this surgery works. It's been peer-reviewed and published in respectable journals and by the American Association of Neurological Surgeons, the Congress of Neurological Surgeons, the Society for the Advancement of Spine Surgery, and the Southern Neurosurgical Society have all peer-reviewed and published this procedure. So he just wanted to ignore all that data. There's no studies showing it doesn't work. There's only studies showing that it does work. And yet he still denied this patient's surgery. So she's still suffering as a result of his being bribed and bought by the insurance company, Humana. And it doesn't just happen with Humana, don't get me wrong. It happens with Cigna, it happens with United Healthcare, it happens with all the insurance companies, because they all make more money when they don't pay for people's care. Their profits go up. All right, we're done here. Mm-hmm. These little fat goblets. Come on. Scope off is off. Good. All right, we're done with the L34. And now we're going to go and do the L45 on the other side. So I'm going to switch sides while Luis comes over here. I'll hold pressure. So we're done treating the left 3-4 disc herniation. Now we're going to go to the right 4-5 disc herniation. Remember, I've already put the needle in while the patient was awake. Now I'm going to put my guide wire through the needle and take the needle out, and then we'll do the same thing, lateral here. I'm sorry?
Gary was on the floor moving your pedal.
Yeah, so drop it and rotate it slowly and perfectly. There you go. That's good. That's the way it should be. Alrighty.
We need the floor on the spring.
All right, who is happy with Zaxby's? Yes? Are you happy that I bought you lunch, or are you happy that we had Zaxby's?
Both.
Would you rather have pizza or Zaxby's?
Me personally, I like Zaxby's.
Zaxby's? All right. You? What? You didn't eat lunch? Sweet Jesus. You're making me feel bad now. I'm serious. All right, forget about you. You're an anomaly. Shot? We're too far south, but that's a little better. Go a little bit north. And I would say, can you drop the floor, or are you all the way down? You're all the way down? All right. All right. So I need to know who wants pizza next time versus Zaxby's. Shot?
You guys had lunch and I didn't even know about it.
Are you kidding me? There's chicken and salad. I am very sorry, doctor. After this, go grab some, if there's any left. I thought they told you. Oh my God. Shit. I feel horrible. Well, I mean, I'm glad you're cracking the whip on these people, but all right, Shot. But you have to let him eat lunch. I can feel the herniation right here at the tip. Shot? Yeah. So now I'm going to advance the tip of this into the disc, pushing the herniation back in. We're almost done. 10, 15 more minutes maximum. Shot? Yeah. Take. Shot? Should be good. So this will be the L45. You can hear her. Is that her heartbeat? So she's feeling the pain. Yeah. What's that? 90, yeah. So that's the beep, 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 right? That's what I'm hearing. Beep, beep, beep. You hear the noise the machine's making? What is the noise? The beep, 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 beep. Heart rate. Right? Yeah, so because we're going through the painful part of the disc, her heart rate is increasing. She's responding viscerally to the discomfort. So, you know, from a conscious standpoint, she's not consciously aware of the pain. But from a visceral standpoint, she is responding through what are called like spinomedullary shot. Oh, that's good. All right, pathways. Basically pain pathways that don't go to the cerebral cortex, they go to the brainstem, and they affect breathing and heart rate and blood pressure and sympathetic discharges. It's just interesting, you know, right?
So do you know the orthopedic group in Desert Regional, Mr. Sir?
No, I don't know them, but my PA worked for them, and then he came here.
I'm trying to remember the name of the guy because he came from Texas.
No, I don't know those guys. I'm a neurosurgeon. I don't know the ortho guys very much. I barely know the neurosurgeons because I can't stand most of them. They're all so pig-headed, stubborn. Arrogant for the most part. I'm very critical of them. I used to respect them, and then I've lost respect for them. They're supposed to be smart, which I'm sure they are, but they don't act like it sometimes. A bunch of children.
Okay, but this one is fine.
Sean, any questions from our audience?
We do have one.
Is that yes or no?
Yes.
Yes?
Yes, a viewer from
Oh,
Facebook
wonderful.
is wondering.
Your voice is too low.
Let me see here.
Go ahead.
So a viewer from Facebook is wondering, how does your technique differ from when you're doing a lumbar DLDR versus a thoracic DLDR?
How does the technique differ doing a lumbar DLDR versus a thoracic DLDR? That was the question. Well, understand something. It doesn't matter if I'm doing cervical, thoracic, or lumbar. The actual treatment that I'm delivering to the disc, the repair is the same. There's no different. It is removing the interposed nuclear material, debriding the annular tear, and removing any extruded nuclear material that's in the foramen or the epidural space. That's really what I do. And I do the same thing whether I'm in the thoracic, the lumbar, or the cervical. Okay? The main part of the surgery is annular debridement, and it's the same for cervical, thoracic, and lumbar, because we're treating basically the same pathology, the same disease. The only thing that differs is how we get there. And for lumbar, I go, as you can see, I go through the back, but I go through the side, 45-degree angle from the spine. So I come out around the flank area rather than the middle of the back where every other surgeon goes in. That's because I'm doing a transforaminal approach. I'll be done in 5 minutes, doctor. For the cervical, I go through the front, through the neck, for the front of the neck, not the back. And for the thoracic is very similar to the lumbar. I go through the back. But there are differences, and they're very important differences. First of all, for the higher up I move in the lumbar spine, my starting point moves towards the midline. And there's a reason for that. And when I get to the thoracic spine, I'm really much closer to the midline than in the lumbar spine. Look at that tear. You doing okay?
Yes.
Thank you, Luis. So the starting point on the skin is a lot more medial towards the midline in thoracic than lumbar. Second of all, in the thoracic you have the spinal cord. It's very unforgiving. You cannot push the tube against the spinal cord. In the lumbar spine there's no spinal cord, just nerves and an empty sac called the thecal sac. So you can manipulate that. You can push against it, no problem. Doesn't do anything. You don't want to push too hard against the nerves or you get a neuropraxic injury. But the thoracic area, you have to worry about the lungs and getting what's called a pneumothorax if you go too lateral on your entry point, or if you don't pay attention to what you're doing, you'll get a pneumothorax. A pneumothorax would be very bad. You'd have to put a chest tube in to the patient, which is a cut along their flank below the ribs, and you'd put a tube outside their lung and you put it on suction and you suck their lung back up. They usually stay in the hospital 3 days while their lung reinflates. So it's more risky doing the thoracic. 3 minutes. Lumbar is the safest and simplest of all the surgeries I do endoscopically, with cervical being second and thoracic being the riskiest. For thoracic Duke laser disc repair, I'm the only surgeon in the world that does posterior transforaminal thoracic discs surgery endoscopically. The only. Nobody else has ever reported it. Nobody else has ever done it. I need to publish it. But in 2020, last year, we did 6 patients. We had 0 complications, and all 6 patients had 100% relief of their pain in their thoracic spine. 100%. Not even 90%, 100%. So it's an incredible surgery for treating symptomatic thoracic disc herniations. Also, the ones that had radicular pain, pain radiating along the ribs, they had 100% relief of their rib pain. So I got rid of their axial pain and their radicular pain with the Duke laser disc repair. So it's incredible. Normally to do that for thoracic discs, you have to crack open the chest, take out ribs, drop the heart and lung, do it in a hospital. Patient goes to the ICU, usually for a week, recovering in the ICU and then on the floor or step down unit for another week, and there's probably a 20% mortality rate depending on their comorbidities. So big, massive, ugly surgery normally, but we do it with a laser. It takes 30 minutes to do. It's a 4 millimeter incision, and it's 100% elimination of pain is my average to date. It's incredible. Now, I've only done 6 patients. It's not a big number. And we've had no complications and 100% success. So, it's kind of a small, what we call sample size, but it is what it is. I refused to do thoracic Duke laser disc repair until last year. And the only reason I even did it was because I had a few patients that were so desperate in pain and there was nothing else they could do. And they tried all the shots and therapy, it didn't work. And their lives were just destroyed by the pain. So agonizing. So I did it. I told them that it was risky. I told them there's a 50-50 chance I'll have to abort the surgery. And they still wanted to do it, and they all paid cash. Except for a couple of work comp. So these people were motivated and they were committed and dedicated to getting it done. And we did it and they're very happy. So, of course, we're billing their insurance and we're going to fight their insurance to get it paid for. And I think we're going to win. So, we're just going to keep fighting the insurance companies to do what they're supposed to do, which is to pay for people's medical care. That's what they're supposed to pay for. Reasonable, medically necessary care. Instead, they're hoarding all the money and making billions of dollars a year in profit while people go without the care they need. All right, that's it. I'm going to get that herniation out, laser off, and then we're done. By the way, that was lateral. All right. Oh, you're kidding. It didn't come out. It's being nasty. Nasty to me. I see you. Playing games. Look at that thing. That time I got it. All right, we're done. Scope off. Turn the irrigation off. Let me have the dilator. Everything off. Woo, see that? That's pretty cool. All right. Any more questions? Did I even answer that question?
Yes, you did. There are no others.
Fantastic. Sorry, it's a long day and I'm a little tired. So I could keep going like the Energizer Bunny, but no need since I've answered all the questions. Great job, everybody. Doctor, fantastic. And it's so nice to meet a fellow Egyptian. I'm sorry you live in Ocala. Whenever you're ready, you can move to Melbourne. It's much nicer here by the water, don't you think? Are you a golfer? Daytona? For what? Just having fun? Good. You have kids? All right, good. Well, it's been a pleasure working with you today, and I appreciate everything. Let's go see how our last patient's doing. He should be ready to go home. So, Sean, let's shut down the broadcast, and let's go see our patient in recovery.
All right.